afternoon to all participants and organizers, and thank you for organizing such a congress, a webinar. So my paper is entitled, as it's written on the screen, Characteristics of the Social Axioms, a study on temporal stability performed on a group of Romanian participants. So generally speaking, I investigated whether a variable is likely to change over time. And that variable is the social axiom. In fact, there is no one, there are a group of five. According to the definition, social axioms or beliefs, social beliefs, are generalized beliefs about oneself, the social, the physical environment, or the spiritual world. They are social because they appear due to the socialization process, and they are axioms, like in mathematics, because people accept and endorse them without too much analysis of their validity. Variables in my study are three social axioms: basic psychological needs and subjective well-being. As I told you before, there is no one social axioms. A five-dimensional structure of social axioms resulted from intense work on identifying a set of general beliefs that apply to different cultural groups. And the social axioms are social cynicism, reward for application, social complexity, fate control, and religiosity. Social cynicism suggests a negative perspective on human nature and the social world. Reward for application refers to the belief that the effort, knowledge, and careful planning of activities and using other resources will lead to positive results. Social complexity relates to beliefs that people's behavior differs from one situation to another, and that problems have multiple solutions. Fate control refers to a complex of views according to which external forces predetermine life events, but humans can predict and change fate or destiny by various means. Religiosity refers to the belief in supernatural powers and religious institutions. And to evaluate social axioms, I used Social Axiom Survey 2, a questionnaire with 40 items. The second variable is our basic psychological needs, resulted from the self-determination theory, a theory that links personality, human motivation, and optimal functioning. Within this SDT, this self-determination theory, the psychological needs are innate rather than learned, innate, essential, and universal necessities for wellness. SDT specifies that people have three basic psychological needs: the need for competence, which concerns people's achievements, knowledge, and skills; the need for relatedness, the people's need to have a sense of belonging and connectedness; and the need for autonomy, the need to feel that people are the masters of their destiny and rule their lives. People need to think that they control their behavior. Satisfaction and frustration of basic psychological needs are the two faces of this concept. As more needs are satisfied, more positive results may be predicted. If needs are thwarted, one may predict negative or adverse outcomes. And to evaluate basic psychological needs, I used basic psychological needs satisfaction and frustration, a general measure, questionnaire with 24 items. And the third variable I used in this study is subjective well-being, the individual evaluation of the quality of life. And to measure it, I use WHO5, the 5 items self-report questionnaire on how respondents have been feeling over the last 2 weeks. Regarding participants' time intervals and some statistics, so I have a group of 51 Romanian female and male participants aged 17 to 94 years. And they filled in the same questionnaire in 3 periods. The periods are T1, T2, and T3. The whole periods last 22 months. I used ANOVA with the repeated measures and t-test for independent samples. I just want to add that the normality of the data was checked with the z-values of skewness and kurtosis, the Shapiro-Wilk test, and visual inspection of histograms. And t-tests were used to investigate the difference between the means of the variables. And here I introduced the concept of relative stability of a variable. So a variable is relatively stable if the values of that variable in n consecutive periods are different, which means the difference between the average values is not statistically significant. As a consequence, the general hypothesis of the study social axioms are relatively stable over the periods T1, T2, and T3, which last from 2019 to 2021. I will present results in 3 or more parts. So first of all, regarding the evolution of social axioms over 22 months over the period of study. What I have, the first result here, regardless of the social axioms, the differences between the means are statistically significant. And the difference between the means of the social axiom in tune are statistically non-significant, which means that social axioms are relatively stable. I calculate the stability according to the gender, the stability of social axiom according to the gender of the participants. And we discovered these differences on social cynicism. So female social cynicism is significantly smaller than male's social cynicism in the first period, just before the COVID. And in the next 2 periods, this inequality regarding social cynicism is kept in T2 and T3 during COVID. Yeah, so female social cynicism is smaller than of males. Regarding the other social axioms, I found only on social complexity that is higher than of males in the last period of study. And this is a little bit, maybe hard to believe, but female religiosity is significantly smaller than that of males. So we note that the mean score for female social cynicism is lower than that of males in each period of investigation. And this inequality aligns with the results obtained for the Romanian cultural context by another researchers, Leungli and Zhu, in a paper in 2012. We may say, in addition, that during COVID-19, that means it corresponds to T2 and T3, the mean score of males' social cynicism is higher than that of females. The mean score of female social complexity is higher than that of males, and the mean score of males' religiosity is higher than that of men. I investigate the evolution of the basic psychological needs over the period, and the repeated measures ANOVA reveal statistically significant differences only between the mean of relatedness satisfaction in the three periods. I apply the gender perspective, but this time on the evolution of basic psychological needs over the 22 months, and we discovered that female competence satisfaction, as it is written, we all see on the screen what happens. For example, female autonomy frustration in the last period of study is statistically significantly lower than that of males. Regarding subjective well-being over the periods, are not statistically significant, as indicated by the ANOVA on the screen. The gender perspective on the evolution of subjective well-being over the period of 22 months. So regardless of the investigation period, T1, T2, T3, the scores of female subjective well-being are higher than those of male participants. However, significant differences between the means of subjective well-being are recorded only in the first two investigations period, T1 and T2. I will reach now to the conclusions part. What we may say, the emergence and manifestation of the COVID-19 virus had no significant impact on the social beliefs of the participants. A possible explanation for this could be the relatively short periods between the three measurements. In particular, the third investigation period was considered immediately after the end of the second period. And we may say that changes in social axioms can likely occur over a more extended period. What we found also is the gender of the participants seems to bring a new perspective to this study. Analysis revealed that throughout the three periods of investigation, social axioms differed for female participants compared to male participants. In other words, social beliefs followed distinct trajectories depending on the participant's gender. Regarding basic psychological needs, the same gender perspective applied to basic psychological needs shows statistically significant differences with the emergence of the COVID-19 virus. For example, male competence frustration is higher than that of females. Relatedness satisfaction, male relatedness frustration is higher than that of females, and male autonomy frustration is higher than that of females. Regarding subjective well-being, in the first two investigation periods of this study, in the pre-COVID period and during the pandemic, females' subjective well-being is significantly higher than that of females. As social cynicism is higher in males than in females, a possible explanation is that females better manage the social belief, resulting in a state of well-being and a more pronounced positive emotion in females than in males. I think it's the last but one of my slides. We believe that the results of this study may be helpful in the field of counseling, aiming to enhance the subjective well-being of individuals, particularly those who exhibit a high degree of social cynicism. Then social cynicism could influence attitudinal reactions to workplace characteristic and therefore job satisfaction. I discovered research, Ip and Long in 2010, that suggests that there is a negative correlation between social cynicism and job satisfaction. Moreover, the authors argue that the individual's perceived well-being would attenuate these effects of social cynicism on job satisfaction. In other words, if people have a high level of social cynicism, then the negative effects of cynicism on job satisfaction tend to be smaller. This aspect becomes even more interesting as concerns about social cynicism across several cultural contexts suggest that Romania registers high values of social cynicism. So it is a paper of Bond et al. In 2004. It is worth noting, along with Bond et al. Of that paper, that both societal cynicism, which characterizes large social groups, and social cynicism at the individual level aim at similar content. I have to say the limitation of the study perhaps are more, but I just want to note that three that are on the screen. The time intervals between the measurements are not equal. Participants are between 17 and 94 years old, and social axioms tend to change throughout the development of human personality. For instance, beliefs during adolescence and those in old age. And of course, the third limitation, important limitation, is that the small sample size in this study, 51 participants only. I would like to, before thank you, I would like to know, because this study is part of a research that investigated the mediating role of social axioms between basic psychological needs and subjective well-being in two different cultural contexts, Romania and the UK. And one result showed that for participants from both cultural contexts, Romania and the UK, social cynicism mediates the relationship between the need for competence and well-being, leading to an indirect effect on improving well-being. So I think this is my last slide. Thank you very much for your attention.
Here you can see the references of the article, which has been published in 223, and the title was Art Therapy and Authority, Anger, Rebellion, and Resilience. This article has been written shortly after the start of the war in Ukraine, and I was very angry at that moment. So my presentation will be mostly creative and not theoretical, because the time is short and art therapy is a practical method. So what we can say, generally speaking, and is that, of course, authority is needed, but authoritarianism and abuse cause pain, trauma, post-traumatic syndromes, suicides, and anger. Okay, so this was the painting I described, made in the last 2 minutes, and being authentic, much more authentic than the long work before it. Okay, next slide, please. So, this was just one example. I might share with you another one later, but in social life, of course, the question of authority is crucial. How do we organize leadership? And then I show you here an art therapy game or protocol, if you prefer, that I called Exquisite Corpses. And it is a creative group experience for minimum 5 participants in the group. It is done through collage and writing, and every participant has his own sheet of paper, A3, chosen by himself or herself, and the paper sheets will move in the group in the game. So the directive is to build a character in 5 steps. The first person will build the beginning of the character, then the second one, the half of the body, upper half, the third person, the bottom half, and then it will be object to attach to the character, and then the space. When the paper comes back to its initiator, author, let's say, then it is a time of verbalizing and writing, sharing and analyzing, and finally discussing about authority and leadership. So please, next slide. So this is a general vision of a group of 12 people. Everyone got back his own baby. Next slide, please. So here you have a detail. You can better see what is in it. And you have the 6 steps protocol. Realizing ahead, which is starting. Realizing the upper half of the body by the next person, which is continuing. Finishing the body with the lower part by a third person, which is the ending. Adding an essential object to the created character, which is about attachment, by the fourth person. Then adding some elements of space and time, which is about location, history, belonging, and finally finding a name and writing a short story. So it is about identity by the initiator, author of the piece of work. And what is very important in this exercise, it is that everyone at every step has to let go what he or she did to another one, and then another one, and then at the end get back something which is totally transformed in a group action. So when I get back my sheet of paper, I can say that in the first time, in the first step, I was the leader. And then I get a paper from my colleague from the left side, and he was the leader because I already will have the head on the paper. And then I got another one where another one was the leader. So everyone is the leader in his turn. So please, next slide. So in this art therapy context, it is possible to have clients stepping from uncontrolled and traumatizing black anger. So in French, they say une colère noire, a black anger, terrible, to positive and sublimated state of mind, which facilitates problem solving and decision making. Please go to the next slide. Next slide, please. So these are the references. So I apologize because in the article there is a mistake that point 2 and point 3 is the same one. So these are references mostly about distributed leadership. So there is a concept which is called distributed leadership, and there are some articles and books. And it is very interesting to see how, for instance, you have developing distributed leadership through art-based and embodied methods, an evaluation of the Austrian action research trials, etc. So you can find my own article is in open access, free in access, and you have more description, more analysis, and even more images. So I invite you to read the article, which is short but consistent, and to try to find these free access references. Thank you. Go to next slide. So thank you for your attention. These are my references, site, Instagram, and email.
I'm really glad I can share my findings with you today. My name is Ania Woźniak. I'm a PhD from university in Poland, SWPS University, in psychological department. Today I will discuss with you the psychological consequences of social responses to trauma disclosure, particularly in the context of sexual violence. I will present some findings that explore how reactions from others influence trauma-related guilt, post-traumatic beliefs, and PTSD symptoms. This study oh, sorry. You can see the next slide, yes?
Yes, perfect.
Okay. The study is grounded in the social interpersonal model of trauma, which highlights the critical role of social environment. Specifically, it assumes that negative reactions such as blame, lack of support, or disapproval following disclosure may worsen trauma-related outcomes, especially for sexual trauma survivors. Sexual violence is one of the most commonly reported traumatic events by women. Up to 20% of respondents have experienced sexual violence at least once in their lives. Also in my study, 20% of respondents had this experience in their lives. At the same time, it is the one of the least frequently reported incidents to the relevant authorities. In Poland, there are up to 2,500 cases reported annually on a year, which is a small group of people who decide to report it. The key social factors emerging in the context of sexual violence are victim blaming, rape myth acceptance, and social support or lack of social support. I identified in my study negative social reactions, which are studied by the social reaction questionnaire, and social acknowledgement studied by social acknowledgement or disapproval questionnaire. The heart of this model emphasizes the cognitive emotional processing of trauma. Individuals internalize and make meaning of their experience, and guilt, shame, and negative self-evaluation are central mechanisms that can sustain PTSD symptoms. Negative social reactions, especially those following sexual trauma, can deepen those mechanisms by giving survivors fast labeling their experience, and which provide assimilation or over-accommodation processing, which deepened guilt, shame, and self-blame. This slide presents the whole theoretical model in my study. Of course, this is the model where I especially focused on the negative specific social reactions, which can provide assimilation, over-accommodation, trauma-related guilt. What is also important that social responses such as turning against and disapproval are posited to influence post-traumatic cognitions and guilt, which then contribute the PTSD severity. The model tests both direct and subsequential mediating effects. Also, I divided to three groups of categories. Participants were in a group of sexual violence experience, intentional trauma experience, but without sexual violence in this, and unintentional trauma, which is the event involved another person, but it was not intentional, or it was the event natural, for example, flood, hurricane, or other natural disaster. Those three groups were then were the most important groups in this study. Sorry. There were independent variables and dependent variables. The dependent variables was post-traumatic cognitions, trauma-related guilt, and post-traumatic stress disorder. The independent variables was type of traumatic event, intentional, unintentional, and sexual violence. And also I had mediators as the social reactions and social acknowledgement. Validated instruments such as social reaction questionnaire, social acknowledgement questionnaire, trauma-related guilt questionnaire, and post-traumatic checklist 5 were used. This was the first use of the social reaction questionnaire in a Polish research context, and also social reactions are mediators in the study, but subsequent. I will tell you about this more further. What was the central question of my research? It was how do perceived social reactions to trauma disclosure affect trauma recovery? The objective was to test both correlational and mediational pathways involving negative social reactions, guilt, and cognitive distortions, such as negative beliefs about self, about others, and about the world. I provide 4 hypotheses which were tested, including correlations between variables, group differences in PTSD, guilt, and negative beliefs, sequential mediation model linking trauma type, social response, and psychological outcomes. I will tell you now more about the social reaction questionnaire, what it measures. Three types of social reaction were measured by this questionnaire. First, turning against, it is the negative reaction, which including blaming, differential treatment compared to before the disclosure, receiving the information without provided support. The most important here was egocentric responses and distraction, or talking about something else after the disclosure. And positive reactions. Positive reactions are not that significant, so only the first two, which are negative, were considered as potential mediators of PTSD symptoms. The measurements I've used in this study were the reliability of these measurements were high and very good. Now I can talk about verification of my hypothesis. First of all, the correlations. As you can see, strong and statistically significant correlations were found between PTSD severity, trauma-related guilt, and negative cognitions. This confirmed the interrelated nature of the emotional and cognitive aftermath of trauma. But also, I identified strong and significant correlations between PTSD severity symptoms, cognitive emotional outcomes, and negative social reactions. As you can see, SRQ, TA is the turning against negative reaction, and WPS is the no support after the disclosure. The correlation is statistically significant and also strong, so that can provide the mediation model, which I discuss later. Verification of hypothesis 2, group differences. Severity of PTSD symptoms, individuals who experienced sexual violence scored significantly higher on PTSD symptoms than both comparison groups. The size effect wasn't very big, it is small, but it reflects a consistent vulnerability in this group. Also, in post-traumatic cognitions, you can see the differences between groups. Again, significant differences were found across all subscales of post-traumatic beliefs. Self-blame size effect was 0.4, negative beliefs about self size effect was 0.2, and negative beliefs about the world and others size effect was 0.6. In every negative post-traumatic cognitions, the group of sexual trauma survivors were significantly different. Also, trauma-related guilt, survivors of sexual violence reported significantly higher levels of trauma-related guilt than other groups. That supports the theory that guilt is a key emotional consequence of trauma disclosure, especially when individual met invalidation or disapproval or blame when they talk about their experience, we can see also that negative social reactions also individuals with history of sexual violence scored significantly higher on the negative social reactions compared to other groups, which are unintentional trauma and intentional trauma. In turning away subscale and receiving information without providing support subscale, we don't have a very big size effects, but still it's significant in this study. Also, I checked general disapproval and disapproval from family and close others. As you can see, disapproval from family and close others was significantly higher in the sexual violence group. Although general disapproval was not significant, the findings suggest a pattern of social invalidation, particularly in intimate context. This is very interesting for me as a researcher. Because I also thought that the general disapproval will be stronger in this sexual violence survivors group experience, but family and close others are more important than general disapproval. Now I will discuss the mediation model. This is one of the models I provide, and one which had the highest percentage of explained variance, 52%, which is high and very significant for us, to understand what is the environment of people who experience sexual violence. I have here a multi-categorical categorical independent variable, which X1 is intentional non-sexual trauma, and X2 is sexual violence, and only for sexual violence we can see the indirect effect for in this model. This indicates that negative social reactions, general disapproval, negative beliefs, and guilt collectively mediate PTSD development. This is, oh, sorry. I don't know why I changed my slide, sorry. This is a very interesting perspective. This is also one of the models. The model with lack of support and turning against, and family and friend disapproval also explained variance on almost 48% and 50% for each models. So the group exposed to sexual violence was and is, I think, most vulnerable to negative outcomes. Negative social responses, particularly turning against and emotional disengagement, identified guilt and maladaptive beliefs contributing to PTSD symptoms. Theoretical assumptions were confirmed in this study. Social reactions act as a secondary injuries for sexual assault survivors, mediating the pathway from trauma to long-term psychological distress. In discussion, I would like to focus on the most important outcomes, not only as a science information, but also as a social social information, social environment information for us, for others who work with survivors of sexual assault, and those who can speak with them as a significant other. First of all, as I already said, survivors of sexual violence are particularly vulnerable to post-traumatic guilt, maladaptive cognitions, and PTSD, especially when faced with negative or dismissive social responses. Also, social reactions such as blaming, ignoring, or emotional disengagement have measurable and lasting psychological effects, functioning as, I can say, secondary injuries. The full mediation model showed that negative reactions lead to over-accommodation and guilt, which significantly contribute to PTSD symptoms. As you previously see, it was 52% of variance, indicating strong predictive validity. And trauma-informed support should prioritize validating response and counteract societal and familial disapproval to promote recovery. What does it mean for us? We should still educate social significant others and social workers how to react to disclosed trauma of sexual violence. My research is still, as I can say, on the road, so I make other research, for example, quantitative, where I speak with trauma survivors about how others react, and in those narratives, I can see how important to sexual survivors is how others react to their trauma. And for me, that's all. Thank you very much.
Hello, everyone. My topic for today is the impact of overprotection, excessive care, and the need for authenticity and solo play on a child's brain development. So my intention is to be a little bit more in the playful mode and to accept all the knowledge. So in today's society, many parents and caregivers strive to protect their children from harm, sometimes to the point of overprotection. And while the intention is rooted in love and desire to keep our children safe, this well-meaning approach can unintentionally hinder a child's brain development and emotional resilience. Excessive care, when it limits exploration and autonomy, may restrict opportunities for growth. So at the same time, an often overlooked but vital part of child's development lies in their ability to connect with their authentic self and engage in solo play. So the brain's need for challenge. The human brain develops most forcefully through experience and challenge. And during childhood, the brain's neuroplasticity, its ability to adapt and form new neural connections, is at its peak. Challenges such as solving problems, handling frustration, or making decisions threaten cognitive pathways and build emotional resilience. These learning moments create the foundation for executive function, self-regulation, and confidence. However, overprotective parenting can deprive children of these critical experiences. When a child is constantly shielded from difficulty, they may become overly dependent on others, experience greater anxiety when facing the unknown, and develop weaker coping mechanisms. And there is this overprotection paradox that it's created, and while rooted in love, overprotection often cultivates fear and insecurity rather than safety. A child's stress response system designed to help them adapt and respond to threats matures through exposure to manageable challenges. And when children are overly sheltered from stressors, their nervous system don't have the opportunity to develop regulatory mechanisms. So over time, this can result in heightened reactivity, emotional dysregulation, and avoidance behavior. Children raised in highly controlled environments may also experience long-term emotional consequences such as anxiety and depression, and due to underdeveloped neural connections in emotional regulation centers like the amygdala and prefrontal cortex. These children may lack the internal tools needed to process fear, frustration, or disappointment. So there is connection with the authentic self, and it's so important for us to allow our children to develop this connection. So in tandem with protecting and guiding children, it is essential to foster their connection with their authentic self. And authenticity is not simply a personality trait. It is this ability to act in alignment with one's true thoughts, feelings, and values. And when children are given the freedom to express themselves without fear of judgment or pressure to conform, they begin to cultivate this inner trust that we all need. And this self-awareness builds emotional intelligence and forms a protective buffer against the stresses of external validation. Psychological research consistently shows that individuals with a strong sense of authenticity are more resilient, adaptable, and emotionally grounded. And for children, this starts with environments that honor their voice and allow emotional expression and nurture curiosity over performance. And because of that, solo play is also a very important and significant part of our child's development, and it's a pathway to autonomy and emotional maturity. An equally powerful aspect of development comes from the time children spending playing alone. Solo play fosters imagination, problem solving, and self-direction. And it is during those moments of quiet exploration that children build independence and a sense of agency. And unlike passive consumption of entertainment, self-initiated play activities deep neural engagement and supporting creativity and focus. Neurologically, solo play stimulates areas of the brain associated with cognitive flexibility, executive functioning, and emotional regulation. It allows our children to process their experiences and emotions internally without external influence. These moments of self-guided learning deepen their capacity to understand the world, to regulate emotions, and trust their instincts. So, developing independence, not isolation. Encouraging independence doesn't mean withdrawing emotional support, but rather it involves guiding from a distance, providing a secure base from which the child can explore. And when children are allowed to make age-appropriate choices and learn from natural consequences, their decision-making abilities mature. Brain region responsible for judgment and self-regulation, such as the prefrontal cortex, are strengthened by repeated practice, not by parental substitution. Supporting a child's individuality while fostering independent play nurtures both self-confidence and secure attachment. And it teaches the child you're capable. I believe in your ability to figure things out, and I'm here when you need me. The role of parents and caregivers is to balance the support with space. To foster well-rounded development, parents must learn to balance protection with challenge, care with autonomy, and presence with respectful distance. And encouraging moments of uncertainty, creativity, and authentic expression creates a rich developmental environment. Children need both support and space to fall, but also to get up again, to feel frustration and learn to suit it, to wonder and to discover. Within this balance, the child's brain not only grows smarter and more adaptable, but also stronger and more connected to its emotional core. So this is my presentation for today. I'm very happy to share my wisdom with you and my knowledge. And thank you so much.
March 2020, the COVID-19 infection has been declared pandemic. This pandemic has caused several psychological disorders in some categories of the population, like children, adolescents, older people, infected people, some categories of workers, like healthcare workers. COVID-19 infection has been recognized in Italy as an occupational injury in HCW and other frontline workers. At the beginning of pandemic, hospitals faced the shortage of personal protective equipment and lack of established procedures and guidance. Effect on HCWs, uncertainty, lack of support, alienation, fear of contagion, guilty, isolation and difficulty, high workload. These result in high level of anxiety, depression, stress, fear, sleep disorders, frustration, post-traumatic stress disorder, and burnout syndrome, especially in frontline healthcare workers. Burnout syndrome is a state of physical, emotional, and mental exhaustion due to the exposure to stressful factors and emotionally demanding situations. Effects of burnout syndrome on workers are low job satisfaction and depression, high turnover, sick leave, high injuries and accident rates, low productivity, interpersonal conflict, workplace violence. ACWs are at high risk of developing burnout syndrome due to the emotional contact with their patients, aggression by clients, long and solitary shifts, and highly stressing work environment. Nurses and physicians are the higher risk. As a consequence of burnout syndrome, ACWs may develop symptoms such as anxiety, irritability, moodiness, insomnia, depression, PTSD, suicidal thought and feeling of failure, and also psychosomatic disorder such as headache, high blood pressures, cardiopulmonary disease, musculoskeletal and gastric disorder, stomach ulcers, and insomnia. During pandemics or other critical situations, protective factors can help HCV to face the emergency. Important protective factors are optimism, resilience, and altruism. The most functional coping strategies are clear guidelines, supervisor support, proper training, precautionary measures, social, familiar, spiritual, and religious support. A previous study about Cacciatori and other in 2021 from an Italian hospital in Lombardy, which was the most high Italian region during the first wave of COVID-19 in Italy, showed that resilience is a protective factor against burnout in HEWs, especially in your eyes. The aim of these studies is to analyze the impact of COVID pandemic on burnout levels of newly hired healthcare workers employed in Italy during the COVID emergency. The hypothesis is that we expected higher levels of burnout syndrome during the COVID pandemic in workers working in this territory. A comparative cross-sectional study was conducted on two different convenience samples of newly hired ACVW employed with different positions, for example, physicians, nurses, other categories, at a public hospital in Lodi. Participants were evaluated 30-40 days after starting their job. They constituted two groups, those employed and evaluated during the 2019 year from January to December, and those employed and surveyed after the onset of COVID pandemic from April to October 2020. Participants of the first group before COVID were visited by psychological instruments that were administered during the clinical interview by trained psychologists. Participants on the second group were surveyed by psychological through online interviews in compliance with safety regulation on COVID. A self-report questionnaire was used to collect the main social demographic characteristics, including gender, age, type of work, and work department. The Italian version of Maslach Burnout Inventory Human Service Survey was used by evaluating burnout levels. According to Maslach's definition, burnout is characterized by high EE and DP and low PI. In this study, prevalence of burnout was measured as sum of height, EE, height, depression, and low PI. All data was analyzed using SPSS version 26. Descriptive statistic was computed to report the demographic in the groups. Difference between before and after COVID groups were evaluated with X test, square test for categorical variables, and ANOVA test for continuous variables. Significant values were set up at a p lower than 0.05. The results indicate that the prevalence of burnout in newly hired ACV was higher in the COVID-19 group than in the before COVID-19 group. Difference in both in burnout frequency and all single sub-dimensions of burnout between two groups were statistically significant. You can see the table of the results of the study. Conclusions. Our findings show a higher prevalence of workers affected by burnout syndrome during the COVID pandemic, as well as significant differences in burnout levels and single subdimension of burnout, which were either in COVID-19 group in comparison with the before COVID group. On the contrary, the mean scores of all burnout subdimension show similar score in both temporal, low levels of EE and EP and medium levels of PA, showing no statistically difference between the two groups. As shown by some systematic reviews, burnout syndrome is inevitable among frontline workers, especially nurses, who are closer to patients than doctors because they work on the ward where patients are managed, and they relate directly with caregiver or family members of patients. Our findings are in agreement with work by Mazzella, Epstein, and colleagues in 2019, showing low levels of burnout in newly hired workers. The limits of the study are the small convenient sample and the cross-sectional nature of our study, limited to infer on the causal relationship between burnout and being newly hired in hospital in the context of pandemic, as there are many potential factors that may confuse this association. This study has also been carried out in the context of an occupational health program, which is needed from protecting the physical and mental health of workers and requested according to Italian health and safety program. Our study suggests the importance of occupational health program for protecting the mental health of HCV, preventing them from the onset of burnout and other psychological disorders. Workplace promotion activities based on meditation, spiritual researches, training to cope with high stressful events may promote higher resilience levels in this category of workers and prevent the onset of burnout and other mental disorders. Thank you for your attention.
Hey, my name is Dr. Kenia Pega, and I'd just like to welcome you to my presentation about the Birthplace model. This is an inventive model and also something that I was the creator and director of the program where we actually are doing the research and we're working with people to heal complex trauma from sexual abuse. Apologize for any background noise. I am on holiday, so it is quite loud, but I'm hoping that it's just picking up my voice. So just launching into the presentation that I'd like to share with you today. I'm just going to get up my share so I can. There we go. Great. It will just take me a second here. So Birthplace is a program that's designed to use a neurobiological approach as well as a somatic approach, empowering survivors of sexual abuse. This is for anybody that has experienced incest, sexual abuse, sexual trauma, any type of sexual assault. So the idea for this is that we have a very complicated profile that comes from sexual abuse, both biologically, neurobiologically, and relationally. And so what we found is that most survivors of sexual violence have some type of complex trauma. And as we look at complex trauma, we know that it has that impact on the nervous system, but it also has the impact on the ability to form and keep relationships. So the program that I designed here, which is a neuroscientific-based program, is really based in the idea of self-regulation and being able to reclaim your body from trauma through self-regulation. So Birthplace itself is a model of growth and empowerment community that addresses the chronic and complex trauma that is rooted in repeated sexual abuse, childhood sexual abuse. We also work with survivors of incest and trafficking. So this has been a program that we have been running now for over a year. And we ran a pilot first and found that the results were incredible in terms of the increase in resiliency. We used the multi-dimensional assessment of interoceptive awareness. So to be able to see whether interoceptive awareness and the ability to self-regulate also increases. And we also look at the traditional symptomology through trauma symptom checklist and other things like that to see whether the trauma symptoms that are a result of the impact in the nervous system also go down. So this program itself is what we call a triphasic model, and it's rooted in the work of Judith Herman, who did a lot of gold standard research around trauma and being able to work with trauma. And so this is an evidence-based program in terms of the interventions, all of the resources, all the tools that we use are based in evidence. And it is a triphasic model, like I mentioned. So it has 3 8-week groups that meet weekly. So each group meets for an hour and a half. It is the same group every week so that the survivors and the participants have the ability to develop safe relationships. We also have designed everything to be non-activating. You know that a lot of the traditional paperwork, a lot of traditional intakes are activating, which means that the person's system in that environment is already going to make a correlation between the environment or the professionals involved in being unsafe. So one of the things that we do is we use a salutogenic approach, which means that we're focusing on health opposed to diagnosis, pathology. We're looking at strengths. We're looking at the ability they have to be able to move through and the things that they might have developed as super skills or abilities opposed to what is wrong with them. So we know that the symptoms are there. The symptoms are obviously there, but those are normal responses to an abnormal event. And so we frame that from the very beginning of course you would have done that. That's exactly what would happen in that situation, opposed to minimizing or saying that it's not true. And we moved away from this from the very beginning of their contact with us into what we call an orientation, which is orienting them to the program and then encouraging them to make a choice. So instead of forcing them into programming, instead of saying this is what you have to do, we're inviting them in and asking them to regulate, assess, and think about whether this is a good choice for this. And we also know that trauma looks different in everybody. And so the way that they express their trauma, the way that they share their trauma, the way that their narrative so far is going to be different depending on the person. So their paperwork doesn't capture that. We also know that it's important for the program to be all accepting and all inclusive. So it is not a woman or a gender-based program. It's open to all different people from all different genders as long as they're 18 and up. And we are looking at expanding into a younger person program, but since we've been running the pilot, the program, we've been focusing on 18 and over. So our program is really designed on helping survivors recognize that the body and nervous system have been wired in a certain way depending on our experience. And their individual experiences will have impacted the way that they react, act, their level of activation. We don't use the word trigger, we use the word activated because we know that it's the system being turned on. So it's not that they're choosing to pull a trigger on something, it's that the system is being turned on due to the fear or the response that have already been programmed or wired in. And the first part of the program is thinking about their journey so far. So instead of doing an intake paperwork, we're using the ability to create a visual story of their journey so far. And a lot of the program is designed to have nonverbal and verbal components so that clients can express what they want to, depending on what feels comfortable for them. The next part of the program, and this is like the first solid 8-week phase of the program, is called the Brain Body Education Groups. And we use the word brain body opposed to psychoeducation because we are really learning about how the brain and body have been impacted by the trauma. And a lot of this is normalization. So this is normalization saying that you have gone through something horrible, you've gone through something horrendous, and let's look at the way your nervous system and your brain and your body are responding to this. Have responded to this maybe in the past, but are also how it's responding right now. And so during this program, this part of the program, we're learning about the nervous system. We're seeing about how their tolerance levels and what their capacity levels are for different stimulus, for different situations, for different types of relationships, for different types of stressors. We're also looking at any patterns and templates they may be carrying with them. And we're holding hope for people to understand that they have the ability to wire in new patterns. So the idea is that these are anything we can wire in, we can wire out, which is great. And we really hold hope for the idea that they can wire in new patterns. Also that they're not stuck in this chronic state of dysregulation. So we talk a lot about regulation, dysregulation during this time. And we also really weave in how the body is responding, how their individual body responds. And a lot of times during this time, the participants are also looking at this from an objective lens because we're teaching it from the neuroscience and somatic lens, and it doesn't feel like a personal attack. So they're learning about their systems, being able to normalize and pinpoint things that are happening within their individual systems, but in a safe context. To greater increase the level of safety, the groups are closed and they have no more than 6 members. So this is really an opportunity for certain people that have never had safe relationships to build relational safety for the first time. We know that healing happens in community and healing happens in relationship. So what we're really trying to do here is to build relationship opposed to the one-to-one therapy model, where you might be building relationship with one person, but you may not be building relationship with peers or with other people. So we're really moving away from that context and moving into the community-based healing approach, where you have multiple relationships to be able to work on, to navigate, to grow with. And again, the participants always have a choice because in the groups, they're structured in a way that we regulate the nervous system, we check in with the nervous system, we do a bit of learning, and then we do an application task. So that might be a task that they take away with them to continue and to work on throughout the week, almost like a homework, or they actually do the task during the group, and then they have the opportunity to share about it or not. But nobody is missing out based on their level of participation. So it doesn't make people exposed. So a lot of healing groups therapeutic groups are dependent on people sharing a lot of personal feelings, emotions, information. And in this, it's about their comfort level. So they find that as they feel more comfortable in the group, they may share more or they may not share at all, but they're there as they're still getting the full benefit from the structure of the program and the way that it is laid out. The next 8 weeks group phase is solely focused on self-regulation. So this is about identifying their individual regulatory patterns, whether there's somebody that goes into hyperarousal or somebody that goes into hypoarousal, or what they're called, what I like to call combined type. So the actual strategies that we're using in this section are custom to their nervous system. So they're going to be able to be exposed to a whole variety of different self-regulation techniques that can be used in different settings, take different amounts of time, but also that they can start to self-reflect on it from an interoceptive basis. Does this work for my system? Does my system like this? And the goal is at the end of this, they will have practiced it, hopefully develop some habits and rituals, but then they will also have an individualized menu for their particular nervous system. So we're really talking in this section about upregulation and downregulation, and knowing that their window, the window of tolerance, or whatever you'd like to refer to it, is going to have shrunk from their experiences of trauma, but that it can be expanded. So we're looking for situations where they might have more regulated experiences, and we're trying to bring that in to their day-to-day life. We also spend a lot of time on dissociation. So a lot of traditional healing programs really focus on that hyperarousal and turning the nervous system down. But a lot of our clients, particularly with body-based sexual trauma that have been trafficked in particular, find that they turn their system off. So we're trying to bring up safe levels of exposure and activation during this stage as well. And one of the most exciting parts of this program is that normally a traditional therapy or a traditional healing program would leave off at that stage. You've got your self-regulation, you've done your psychoeducation, but we have a full phase, which is called post-traumatic growth. And this 8-week phase is designed to support participants in building new patterns, new rituals, new routines, but it's really based on passion and purpose. So when you've been living in a dysregulated body, you're really living in survival. You're not really getting the opportunity to live into passion, purpose, any of those other things. So in this section, we're really working with participants to grow self-esteem, to grow confidence, to understand boundaries and healthy relationships, to be able to start to work with their body, to be able to express what they want, and to no longer have to live in a dysregulated state all the time. A lot of trauma survivors describe that when they get regulated, they don't know who they are or what to do with themselves. So this part is really about designing the life that they've dreamed of, to shed any of the stories or the narratives that no longer serve them, and to move into that regulated and resilient lifestyle. And this really includes building those safe relationships and refining the ability to manage their stress response. So getting more skills around what does my day-to-day stress, not the trauma responses, but the day-to-day stressors that everybody encounters in life. How do I move through those successfully and confidently? And so we're really looking at being able to build, at this point, a whole person that understands what's happening in their body, that understands how their body responds, but then is able to do something with it, to move through it successfully. And this last group is where we see probably the most social and emotional growth. We see people start relationships, leave relationships. We see people from our program that have decided to return to college, have decided to seek further education for the first time. We see people that are getting jobs, that are also leaving jobs and finding jobs that have more meaning and purpose for them. And also people that are starting to give back to the community, that want to be able to share the program and the healing that they've experienced with other people. So this is a really important part of the program as well, is that when somebody graduates from the program, they're encouraged to stay part of the community. So what happens is that in traditional programs, you're discharged. So you're discharged from programming, you've graduated, you've got your certificate of completion. But in Root Place, we have the opportunity for people to continue to be part of the programming. And we do that through enrichment activities where we get providers, lecturers. We think about the whole body. So at this point, we're adding in perhaps more movement exercises. We're working on nutrition. We might have special offerings and information about sleep. So we're thinking about the holistic person. How do we support the survivor as they move to thriver and they're back living their best possible life? And at the end of this program, we also come back to the journey plan and say, okay, where would you like to make any adjustments? Would you like to create a new story? How would you like your journey to look like moving forward? And that's really important because it's that self-reflective piece as well. And also taking back their life. So when we think about taking back their life, that's a major step, saying this is what I want. We also have the opportunity for people to continue to remain active in the program as ambassadors who attend events and share about our program, as peer support specialists. We will be having some graduates that will actually be getting employment through our program. And we also will be having special interest groups like a book club where participants get to lead as leaders with other participants that may be new to programming. So the idea is that they continue to stay part of the community if they'd like to. Other people graduate and they're done and they're living their best possible life. And some people choose to be able to stay part of the community. But the idea is that we're allowing people to have self-reliance and self-esteem. And our goals of the program overall, like I said, is to increase resilience, of course, to increase interoceptive awareness, to reduce trauma symptoms. But we also have these wider goals, which is to increase the understanding of how chronic and complex trauma affects the participant's body, brain, and behaviors, to be able to have decreased activation in the participant's day-to-day life, and reduced avoidance and also reduced dysregulation overall, to promote cognitive growth and reframing. And this is one of my favorite parts of it, which is the idea of moving from survivor to thriver. And through all of this, we're creating an all-inclusive community that doesn't end when the program ends, if that person would like to stay part. So we've had people that have made friends They continue to stay in contact. We have people that have wanted to repeat the program because things in their life circumstances has changed, and we do not discharge people. So they are always a community member, even after completion of the program. So this is our website, and it's www.ruthplaceaz.org. And the most amazing thing about our program is because it is a neurobiological and somatic coaching program, we can accept participants from anywhere in the country as well as anywhere in the world. So we are based in Arizona, but people are welcome to join our program from any place that they'd like to. And we accept self-referrals, we have scholarships, and we can also do specialized small group programming. We ran a pilot where we did a small group programming for a home for people that had been safely taken out of trafficking. So we can do small group programming as well. So please feel free to contact me at Ruth Place. And also, if you have any questions or you'd like to talk more about the program or the possibility of partnership or collaboration, I would love to hear from you. And again, our goal is to build hope for future and healthy, supportive relationships through safety, empowerment, and regulation. Thank you.
Good day, everyone. So my name is Dr. Christine Rio Bustis Nadala. I am a psychiatrist trained in psychoanalysis, but more than anything, I come before you today as a sibling and as a caregiver. Before I play the video presentation I prepared, allow me to share a few words. So what you're about to see is deeply personal story. It's not a lecture in a traditional way, but rather a lived reflection, a journey that began with my youngest brother's rare cancer diagnosis and unfolded into something I never anticipated, a transformational of how I understand love, caregiving, grief, and selfhood. So, as someone shaped by Southeast Asian values and by psychoanalytic thinking, I found myself navigating between two worlds, between science and faith, between caregiving and letting go, between personal pain and professional insight. So this video, Beyond the Unknown, Navigating Transformative Journey of Caregiving Through Rare Cancer, is based on an article I wrote that traces this journey across three phases: the search for answer, the demands of treatment, and the difficult but sacred process of acceptance. In this presentation, I invite you to listen not just to a story about rare illness, but to a story about what it means to accompany someone you love through suffering, how caregiving is shaped by culture, informed by psychoanalysis, and sustained by vulnerability and presence. So with that, I thank you for being here with me today, and I now invite you to join me in viewing this short but heartfelt presentation. Hello, everyone. I'm Dr. Christine Rio Bustis Nadala, a psychiatrist with training in psychoanalysis. But today, I'm here not only in my professional capacity, I'm here as a sibling and as a caregiver. This talk is intensely personal, rooted in a journey that has profoundly shaped my life, and I believe resonates deeply with those in medical and mental health fields. This talk is based on my article, Beyond the Unknown, which delves into the transformative journey of caregiving, especially caregiving within Southeast Asian context, where family and community bonds are central to well-being. In this context, caregiving isn't just an act, it's a shared responsibility, a part of who we are. Introduction. Entering uncharted territory. Caregiving through rare cancer is a deeply unfamiliar landscape. For my family, this journey began with my youngest sibling B-Boy, who was diagnosed with a rare type of cancer known as monochromatic synovial sarcoma. These diagnoses opened the door to an intense and often daunting journey, one that demanded not just medical expertise, but also resilience, vulnerability, and the courage to confront the unknown. Today, I'll walk you through 3 phases of this caregiving journey: diagnosis, treatment, and acceptance. Each phase presented distinct challenges and taught invaluable lessons that echo deeply with psychoanalytic perspectives and themes relevant to Southeast Asian culture. Phase 1: Diagnosis, when life becomes precious. The initial diagnosis marked a time of profound vulnerability. As the only doctor in my family, I felt the dual responsibility of guiding my family through medical decisions while also being a source of emotional support for B-Boy. In Southeast Asia, caregiving is typically a family affair where roles are shared and emotional support is collective. This communal approach became our anchor, grounding us in faith, shared family strength, and the comfort of leaning on each other. During this period, I sought solace in mindfulness, prayer, and mentorship. It was an emotional upheaval, but it taught me that vulnerability is not weakness, it's a form of resilience. Vulnerability allows us to stay open to our loved ones' needs and create spaces of empathy and connection. From a psychoanalytic lens, I see this phase as an exercise in holding. Holding means creating an emotional space where our loved ones feel supported and secure even as we struggle ourselves. For our family, this meant giving B-Boy a space where he could express his feelings and fears without having to shield us from his pain. This holding became a shared act of love, resilience, and ultimately strength. Phase 2: Treatment, embracing joy amid challenges. As B-Boy entered treatment, our journey became a series of adjustments and adaptations. His chemotherapy lasted nearly 2 years, a period marked by highs and lows, small victories, and challenging setbacks. During this phase, we learned the importance of celebrating life's small moments. Despite his treatment, B-Boy made the brave decision to marry, a choice that reminded all of us that beauty and joy can exist even amid great pain. This decision was not an act of denial, but a testament to resilience, a reminder that love and life continue. In psychoanalytic terms, this phase revealed the significance of finding meaning in suffering. As caregivers, we embrace the concept of the good enough caregiver. We did not need to be perfect. We only needed to be present. This idea showed us that imperfection is okay as long as the intention and support are genuine. Family dynamics became complex as each member coped differently with the emotional toll. I found myself balancing control with surrender, learning to let go of the aspects beyond my reach. Relinquishing control, I realized, is an act of compassion. We were there for B-Boy not by micromanaging his care, but by offering unconditional love and acceptance. Phase 3: Acceptance, honoring autonomy and finding peace. As B-Boy's condition worsened, he made the courageous decision to forego further treatment, choosing instead to cherish the simple joys of each day. This shift was a humbling experience as my role as a caregiver transformed. No longer focused on preserving his life, my role became one of honoring his autonomy and supporting his decision. In psychoanalysis, we speak of the unconscious third. This concept refers to an invisible space shared between two people, which fosters empathy and mutual understanding. In B-Boy's final days, I felt this presence strongly. His choice to accept his fate forced me to confront my instinct, to fix things, to make everything better. I came to realize that part of love, part of genuine caregiving, is learning to let go. Culturally, this phase highlighted a Southeast Asian belief in acceptance and surrender. It allowed me to move from being a caregiver focused on preserving B-Boy's life to someone who honored his journey as his own. This phase wasn't just about death. It was about a profound transformation in how I viewed life, autonomy, and acceptance. This journey taught me that acceptance isn't just passive, it's an active, evolving process. It required me to witness B-Boy's experience and allow it to shape my understanding of life and death. Grieving is a dynamic, non-linear experience. Often, caregivers feel an overwhelming need to control outcomes, to shape events according to what we believe will bring comfort. But caregiving, as I learned, is about surrendering that need for control, honoring the autonomy of our loved ones, and finding strength in respect. In Southeast Asia, our journey mirrored the region's deep-rooted respect for family roles and personal choices. Letting B-Boy make his own decisions, even the choices to decline further treatment, became a lesson in humility, respect, and honor. The grief we felt was not only individual, it was communal, shared, and deeply connected to our family's cultural values. In this way, grief was not something to overcome, but something to experience together as part of our family's ongoing growth. As caregivers, we often focused entirely on the needs of our loved ones, that we neglect our own. In our journey, I came to understand the significance of self-care, discovering that taking time for solitude or maintaining a journal was not a selfish act, but a necessary one. Self-care became a radiant force in our lives, a grounding practice that helped me remain present and resilient. Within Southeast Asian culture, balancing one's well-being with others' needs is often seen as a cultural duty. Yet, I found that the caregiver's emotional state directly influences the patient's experience. Psychoanalytically, this aligns with the concept of transference, the idea that emotions, whether spoken or not, are felt and carried by those we care for. In caregiving, our emotional presence is a form of energy, an influence that impacts our loved one's sense of peace and comfort. Conclusion: a journey of love and transformation. In closing, I encourage all caregivers to see their journey as an opportunity for transformation. Southeast Asian caregiving is about community, resilience, and shared love. By honoring the sick, embracing vulnerability, and prioritizing self-care, we elevate our caregiving. This journey, in all its complexities, is a testament to the resilience, compassion, and enduring strength of human spirit. Thank you for allowing me to share this deeply personal journey with you. Caregiving in any culture is a sacred role. By nurturing our loved ones, we find ourselves transformed and discover our shared humanity in the process. Salamat and mabuhay. Thank you for watching. Each time I revisit this story, I'm reminded that caregiving is not fixed role. It's a shifting, deeply human experience that teaches us as much as about ourselves as it does about persons we're caring for. So in sharing this journey, my hope is not just to speak about one rare illness or one family story, but to offer a space for all of us to reflect on the invisible labor, the emotional weight, and the quiet strength carried by caregivers, especially in Southeast Asian context where care is often communal, expected, and rarely named. Psychoanalysis helped me name what was previously unnamed: the holding, the surrender, the unconscious ties that shape our responses. But it was love and my brother's courage that made the theory come alive. If this presentation resonated with you as a professional, a caregiver, or simply as a person, I hope it sparks conversation, not just about caregiving and illness, but about presence, meaning, and the power of staying with. I welcome your thoughts, questions, or even stories of your own. We now have some time for question and answer. Do we have any
Yes,
time
we
or
do
no?
have. Yeah,
Okay.
we do have.
And I'd be glad to hear your reflections or response to any that stirred something in you. Anything?
Yeah. So thank you so much for sharing something which is so personal and powerful with us. It truly moved me, especially as someone who is both an aspiring psychiatrist in the USA and originally from the South Asia. Hearing about
Oh,
yeah, I'm from India, basically. Hearing about your caregiving journey in the context of rare cancers reveals such a deeply emotional and human side of medicine that I think we don't often talk enough about. And as I continue learning about the psychological dimensions of caregiving, I have become increasingly curious about the field of of psychoanalysis. It seems to offer a very unique lens on trauma, identity, and emotional resilience. I was wondering, could you share your thoughts on how like psychoanalytic ideas or practices might intersect with caregiving experiences, like you have described, and especially like since you are the first doctor in your family. So
oh yeah, indeed. Thank you for that question, Dr. Ayushi.
Ayushi.
Um, Yes. With your question regarding psychoanalysis, as what I've shared, that before, although I was trained in psychiatry, and we have a little discussion about psychoanalysis, and in our textbook, there's only one chapter about psychoanalysis.
Yeah,
And
that's
so
right.
when I immigrated here in the US, I went to training for 6 years in psychoanalysis. And so in psychoanalysis, I've learned the terms, the thing that I've been doing in the past when I'm doing the caregiving, those terms, the holding, the transference, the surrendering, and the meaning making are actually concepts of psychoanalysis. And those are the terms that actually gave me the names of those actions, of those things that I've done during my caregiving journey. And not just during those time, I'm still doing the caregiving now as my parents are aging. They're now in their 70s, in their 80s. And so the journey of caregiving continues, not just in caregiving for the sick, for the ill, but also for your elderly mother or elderly father, and even uncles. As you see, Filipinos, I'm a Filipino, and so
Oh, that's
as
nice.
a yes, as a Filipino, we are our culture is having an extended families. So we don't just care for our mother and father, we also care for our uncles and aunties. So
Yeah, I
so yeah.
understand.
That's why it's really true that psychoanalysis gives the humanness to medicine.
Yeah.
Not just being objective. Objective is really good, you know, because that's the way things are. But we also need to encourage our reflectiveness and our own emotion, our own selves, because that's our stethoscope on learning how to feel others and to be more empathetic in our art, in the art of medicine. That's why it's called art of medicine.
All for joining me for a session on applying attachment theory principles to trauma-informed treatment of human trafficking. I hope this is a robust conversation. What I'm going to do is share my presentation with you first, and then take questions or thoughts or comments or reactions afterward, so that this way we can, have a collaboration of information on behalf of the victims of trafficking. So first, let me begin with an agenda for our presentation today. First, I will talk about the universe of human trafficking, then who's affected, who are the victims in particular, and then talk about who the perpetrators are. Then we'll move into the principles of attachment theory and how that pertains to the issues affecting victims of trafficking. Then we'll talk about trauma-informed treatment and its relevance to human trafficking and its connection to attachment theory in particular. And then we'll conclude with a discussion on protecting against human trafficking and offer up my final thoughts. So one of the things that is significant about human trafficking is that it operates in the shadows. It cannot thrive in public where people know who the perpetrators are and who the victims are. Anyone who is a perpetrator of human trafficking has to operate beneath the radar. So just so that you know, human trafficking in itself is a crime of exploitation where an individual is compelled for labor or sex acts through force, fraud, or coercion. And in addition, it includes those individuals who are under 18 forced into commercial sex. So just so that we're aware, human trafficking knows no borders. It is domestic and international. And it is domestic servitude, all forms of child labor and child soldiers, forced marriage, and even bond servitude. Now, in addition to these categories, one of the things I'd like to bring up is that trafficking can be involved in something as simple as getting a nursemaid for a young child and not paying them fair wages, holding their passport or green card, and not letting them move around freely, literally holding them captive to do the work of an individual. And that is a simple manifestation of human trafficking. So one of the things I wanted to share with you is that human trafficking is a multi-billion-dollar industry. It brings in, at minimum, $250 billion annually. And when you think about $250 billion across multiple nations, across industries, across criminal syndicates, you realize that there's too much at stake to let the victims go free. There's too much at stake. Think about it. The perpetrators of the crime use every conceivable violent tool to control the victim. So one things that my research has found is that modern human trafficking is akin to slavery or contemporary slavery. And it is defined as globalized criminal enterprise and is operated through financial systems that are global, crisscrossing national borders and unimpeded by the nation state. Now, one of the things that I wanted to bring to your attention is that there are a plethora of victims of human trafficking. Men, women, girls, boys, it doesn't matter. They are all potential victims. But women and girls are disproportionately affected due to gender bias that devalues girls from birth and throughout their lifetime. Now, one of the things that I wanted to bring up is that 1 out of every 4 adolescent girls between the ages of 15 to 19 are neither in education, employment, or training for employment. This is compared to 1/10 of boys at the same age. This means that without the protective factor of education, employment, or training, girls are more than likely to be the victims of human trafficking and fall easily into that snare. In addition, females living in forced marriage, 1 in 10 were forced through kidnapping or after being coerced to travel abroad. So forced marriage is also a critical issue that seeks to harm, not to free. So who's affected? Right now, there are at least 27 men, women, and children worldwide who are affected by trafficking. And importantly, victims may not even know they're in a trafficking situation until they can't get out of it. And that's critical because finding them to save them from trafficking is equally difficult. So not only is it difficult to get out of a traffic situation, but it's also finding the victim. And I'll get into that in a moment. But who is at risk? One of the things that is critical is immigrants with language barriers, because they don't know the language or the culture to call for help. So they stay in a traffic situation in hopes that it will improve. Also, persons with abusive histories, physical, sexual, and emotional. These abusive histories diminish an individual's humanity, makes them question their purpose in life. And for that reason, it's sad to say, but it's very difficult for them to get out of a traffic situation when they're in it. Then also, individuals with intellectual or learning disabilities. These are our most vulnerable individuals. And not only do they not know how to ask for help, but more importantly, they are devalued because of their intellectual or learning differences. Whether it's reading, developmental disabilities, what you name it, whatever the reason is, they are kept from moving and propelling forward. And this is a really hard pill to swallow. And then finally, persons with few food or housing insecurities. When you do not have the basic necessities, you are at risk of being fodder for a perpetrator. And that is significant. So who are the perpetrators? One of the things about human trafficking is that it's a low-risk, high-reward crime. There are individuals, criminal syndicates, corporations, and nations. And the US State Department asserted that 11 governments in particular engaged in trafficking people through sex and labor. These countries are Afghanistan, Burma, China, Cuba, Eritrea, Iran, North Korea, Russia, South Sudan, Syria, and Turkmenistan. Now, one of the things that's important to note is that once you're caught human trafficking, the penalties are swift. It's finding the individuals who are trafficking that is critical. You may find them, but in order to convict them, you need the testimony of the victims, who are very reluctant to testify. So back in 2022, only 1,070 defendants were charged with 3 types of trafficking. 91% were male, 58% were white, 20% were Black, 18% were Hispanic, 95% were US citizens, and 71% had no previous convictions. So understand, that is such a low number for the amount of people that are trafficked every year. So just bear that in mind, that what I said before about it being a low risk, high reward crime, it is so true. You're highly likely not to be punished. So let's move into attachment theory. Attachment theory postulates that behaviors in which a maturing individual engages in order to maintain proximity to their attachment figures. These behaviors are predictive of adult relational patterns, though there is significant evidence to demonstrate they can be changed. One of the things about attachment, from the time we are born, we seek to attach to a protective figure. That protective figure is going to give us food, shelter, support, emotional support, guidance, direction. That's who that protective figure is. And when we talk about human trafficking, the protective factor becomes the perpetrator. They give you clothes, they give you food, they give you shelter. They may give you money. And your belief tends to change with the mindset that this individual is my protector. So there are 4 types of attachment behaviors. First, secure attachment, insecure avoidant, insecure resistant, and disorganized disoriented. I'll explain each of the 4 and then come to a discussion about that. First of all, secure attachment results when a child is distressed when the caregiver leaves, but is easily comforted when the caregiver returns. Insecure avoidant means the child is indifferent to the caregiver's presence and avoids them upon return. Insecure resistant means the child is anxious before separation and shows ambivalence or resistance to the caregiver upon their return. And disorganized attachment, which you see in abusive relationships, means the child displays a mix of behaviors that indicate confusion or fear toward the caregivers. Most of the victims of trafficking fall in line with disorganized, disoriented attachment. The trauma that is that results from the abusive relationship results in a level of fear and stress that leaves the maturing individual feeling as though they're in a bind and they cannot escape. And that is the critical mass of a victim of trafficking, is the desire to escape, but usually one cannot. So to overcome obstacles created by insecure attachment patterns, the maturing individual must be in an environment in which they can form secure attachment with some protective figure. So why is attachment theory significant? Well, it explains the source of maladaptive behaviors and also helps us think about therapeutic interventions. For instance, if you are working with an individual who is a victim of trafficking, you can be that source of protective figure that allows for the individual to move through a continuum of support, guidance, trauma-informed care, those sort of things. So you become the protective figure and you help erase the damage that was done by the predator. One of the things I like about attachment theory is that it provides for more focused interventions than those based on ecological theory or environment. Environment is very important, but one of the things about attachment theory is that it's critical to the relationship between the victim and the abuser. And if you can transform the victim's mindset about the abuser, you're in a good way. So, like cognitive behavioral theory, it is intended to change the structure of behaviors, but unlike CBT, attachment-based therapy has a focus on specific types of behaviors and thoughts critical to attachment. Change the attachment relationship, you transform the individual. Now, there are limitations to attachment theory. First, it does not explain problems that may result outside of the caregiving relationship. For instance, biological factors, school or community experiences, the effects of race, poverty, or gender are not explained by attachment theory. It focuses purely on the relationship between the maturing individual and the protective factor. One of the things is that attachment theory focuses on thoughts and real events rather than behaviors. So what you need to know is that interventions based on this theory are still being derived, and we're still making headway on attachment theory applications, but we still have a long way to go. So it really is a work in progress. So let's talk about trauma-informed treatment and human trafficking. As I mentioned before, and I'll say it again, victims of human trafficking share a symbiotic relationship with their predator. That relationship is immersed in violence, coercion, sexual abuse, and emotional abuse. It is a relationship of tyranny. Human trafficking is violent because it removes power, freedom, and autonomy from its victims. So what I want to bring to you, the US government in its research on human trafficking came up with 3 primary approaches to stop human trafficking before it occurs, reduce its impact, and mitigate lasting effects. And most importantly, prevent it from reoccurring. So these are the 3 approaches: a primary prevention approach, secondary prevention approach, and tertiary prevention approach. With the primary prevention approach, the focus is to prevent violence before it occurs. So that means building awareness of personal risk factors, providing peer support, promoting access to critical services, making certain that the list I gave you of the persons who are affected is targeted, and we reach out to those individuals to make certain that their needs are met, not by the perpetrator, but by a holistic organization. Secondary prevention approach is to provide an immediate response to violence after it occurs. So this is when the victim is in the snares of trafficking. And one of the things that is critical to this approach is connecting to safe and responsive emergency services, health and mental health care, which is critical because trauma-informed health and mental health makes a difference in allowing the individual to see themselves beyond the life of victim. And then also housing is critical. One of the things that I will say to you is that on any given global street or thoroughfare, there is a runaway kid, a street kid. That kid is a potential victim for trafficking because they do not have housing, they do not have education, they do not have access to health care. That child is at risk of being a victim. And at risk of being in the snares of violence. So that's why secondary prevention approach is critical. And then finally, tertiary prevention provides long-term ongoing support after the violence occurs. And this really speaks to making certain that victims have supportive services, long-term housing, job training, legal advocacy, therapeutic counseling, and anything else they need to prevent re-victimization and support long-term psychological and emotional outcomes. So with trauma-informed treatment, the focus is multi-level and holistic. The goal is to impact recovery, well-being, and reintegration into mainstream society. And here is a list of how that is achieved. One of the things is long-term constant support. If you're in a trafficking situation for 30 days or 5 years, the violence you have endured is significant, and you need long-term consistent support. In addition, secure and suitable housing, as I mentioned repeatedly here, safety from any trafficker or other abuser. It is not uncommon for a victim to go from a traffic situation to an abusive relationship later on in life because they don't know how to discern what a healthy relationship is. So that's why that's critical. Access to medical treatment, access to education, compassionate trauma-informed services, which we mentioned, and most importantly, finding purpose in life and being able to have self-efficacy and self-actualization. So one of the things that I want to bring to your attention about protecting against human trafficking is that all of us must value human life and make significant strides to protect at-risk individuals from the snares of trafficking. And there are steps that we can take, and that includes educating, identifying, and supporting the victims through their situations. And this involves these 3 items here. And the critical mass is reimagining contemporary human trafficking as contemporary slavery and understanding human trafficking as a multifaceted continuum that is low risk and high rewarding. And then finally, dismantling the belief that sex trafficking is more prevalent than labor trafficking, attacking the profit margins of traffickers, and emphasizing evidence of the humanity of victims by prosecuting perpetrators and making certain that victims are protected at all stages of the criminal justice process. Basically, dismantling human trafficking takes a concerted effort from governments, organizations, industries, and individual advocates. If we don't diminish it, more persons will fall victim to human trafficking and have their freedom, power, and autonomy taken away from them. Here is my email, and just so that you know, the book of Chaos of Contemporary Slavery will be published soon by Intech Open.
Today I'm going to be talking about spinal pelvic fixation, specifically the sacral alar iliac screw. So I'm going to start off by giving an outline so that we know exactly what I'm going to talk about as I go through the talk. So first, we're going to go through some indications of when spinal pelvic fixation is useful to be performed. Then we'll talk about some of the challenges that arise with this kind of procedure, the risks that we should be aware of. We'll also talk about some of the anatomical landmarks that we're going to be looking out for. Then we'll discuss how to set up in the OR. And we'll go over some of the imaging, which is important because this will help us with the visualization to make sure that the procedure is performed in the most optimal manner. And we'll even discuss some of the instrumentation and the instrumentation that we recommend that you use in order to perform the procedure. And lastly, we'll finish off with the case. Okay, so now let's talk about some of the indications. So when is spinal pelvic fixation useful? So it's helpful when we want to perform a long arthrodesis, when we need to extend the construct into the sacrum, or if you have a patient that has unstable sacral fractures or a high-grade spondylolisthesis. It'll also come in handy when we need to correct for any pelvic obliquity or lumbosacral deformities with something like an osteotomy. So now let's talk about some of the challenges that arise within the patient when performing this kind of procedure. So the thing that we're always concerned with is any pseudoarthrosis or fixation that may fail on you during the procedure. And this will occur due to the poor bone quality of the sacrum, which we can see here in this image on the right. So we like to get a CAT scan so that we're aware of that bone quality and we can see it clearly here. We also want to be aware of the complex anatomy in the patient when we perform this procedure and the biochemical loading that occurs at the lumbosacral junction, because there's this large cantilever effect that occurs due to the long construct, and it can result in a lot of raw breakage of the hardware. Another thing that we have to make note of is that in certain techniques, like the Galveston technique or the iliac bolts, there can be a lot of screw prominence in relation to the patient's skin. So these are just some of the challenges that we need to be aware of when preparing to perform this type of fixation. So now let's talk about some of the challenges outside of the patient themselves. So within the hospital, we can find other challenges. So in the US, the fixation can be performed in several manners, and one of those is with navigation. So some hospitals in the US use this equipment called the O-arm, and it can cost anywhere from $600,000 to $1 million. So this can be very cost prohibitive depending on what part of the country you're in or what part of the world you're in. And some surgeons have even reported completing the fixation with robotic navigation. And so in the US, the most common form of that is the Maser X robotic system. And that will cost anywhere from $550,000 to $850,000. And so we also have to keep in mind that there's yearly maintenance fees and estimated disposable costs per case. And that'll be anywhere from $1,500. So as we can see, cost can be a very prohibitive factor when considering whether to proceed with this type of fixation. So that's one of the reasons we wanted to give this talk, so we can show you an alternative way that is more accessible cost-wise to perform this fixation. So now we can go over some of the risks about this procedure. And the reason there's risks is because there's a tiny window that we're working with. And so we're worried that if the screw violates the corridor that we're trying to place it in, then you could injure the lumbosacral trunk, which we see here on the right. Or you could even damage the vasculature, which includes the internal iliac vein and the internal iliac artery. And if the screw goes even more medial, you can injure the bladder, which has been reported in previous cases of this fixation. So we have to be aware of these risks. So now let's talk about the landmarks. And there's some consensus on the placement of iliac screws in the Galveston technique. And here we're talking specifically about the sacral alar iliac screws, the S1AI and the S2AI screws. So the patient is going to be positioned prone on a radiolucent table, and you're going to want to pad all their bony prominences and palpate on specific landmarks. So the most important is going to be the anterior inferior iliac spine, because essentially this is the area that we're aiming for. That's where screw is going to reside. So we want to go in front of the patient and make sure we can palpate on that area. And then we're also going to palpate on the posterior superior iliac spine and the posterior inferior iliac spine. We'll also want to palpate along the sacral crest, both the median and the lateral areas, as well as the greater trochanter of the patient. So now let's talk about the room setup. So it's important to put the fluoroscopic image on the opposite side of the table from where the surgeon is going to be standing. That's the most important. That's number one here. So after that, we're going to want to mark the midline, and we're going to prep the area and drape as we're showing here on the right. So we're draping in a fashion that everything is placed as far distally as possible from the intergluteal cleft here, so that we have enough space, because we're going to be using every millimeter of this space for the procedure. Okay, so now let's talk about the entry point of where that sacral alar iliac screw is going to enter. So this is really hard to find in one consistent place. So that's why we want to give you this talk and show you that there's a morphological entry point, and we can find it by, if we imagine this vertical line at the intersection of the lateral sacral crest, and then we draw another horizontal line at the midway between the S1 and the S2 dorsal sacral foramina. Here, that's where we're going to find that intersection, and that's the entry point. But we have to be aware that this is going to be a little difficult to find for a couple of reasons. And one of those is going to be that there's going to be a lot of overhang from the PSIS. And the second one is that when you're performing this procedure, you're going to notice that there's an upward slope of the lateral sacral crest. So we're going to run into some bleeding from the arterial branches and the lateral sacral artery. So those two bony landmarks are going to make it so that the visualization is obscured. So now let's talk about some of the instrumentation. So there's two ways we can go about this procedure. And the first one includes using the awl, which can be curved or straight, and it looks like this instrument right here. And the second way, which is the way we recommend and the way we're going to be discussing in this presentation, involves a 3.5 millimeter threaded long guide wire and an oscillating drill. And so we'll go more into the detail as to why we prefer this instrumentation and how this can help guide you throughout the fixation to make sure we get that optimal location and trajectory. So now let's talk about the trajectory. So earlier I was mentioning the anterior inferior iliac spine. So that is what we're going to be aiming for. That's the goal. And what you're going to do is you're going to cross the sacral iliac joint, and you're going to penetrate at two different cortices of the sacrum and the outer iliac cortex. So we're going to go through the sacrum twice and then go through the cortex itself. So right here where we see that blue dot, that is where our entry point is going to be. And we have to keep in mind these trajectories because this is where we're aiming for. So this is where we're going to be placing that screw. So now let's go into more detail as to how to optimize the trajectory with that second guide wire. So when we're performing this procedure, you might not get your first guide wire exactly where you want it to be. So the good thing is that we can course correct with the second guide wire. So as we can see here in this first image, that first guide wire right there, that's in the teardrop, it's a little too north from where we would want it to be. So we can insert a second guide wire closer to the center of where we'd like it to be in the teardrop. And then we can remove the first guide wire, which will help us course correct and guide that second guide wire to where we want it to be located. And then once that first guide wire is removed, we'll be left with that second guide wire positioned perfectly in that center of the teardrop. So this helps with course correction, and this is one of the main reasons why using that guide wire is the better method for performing the spinal pelvic fixation, especially when we might not have access to those expensive equipment like the O-arm or the robotic navigation that I mentioned earlier. So now let's talk about what we're aiming for. And during this case, the reason we can do it so safely without the O-arm or the robotic navigation is that we can get a specific view called the obturator outlet view. And this will give us that teardrop outline, which we can see here on the right. It's that pink teardrop that we're seeing, and it's in the hemipelvis. So this represents the superimposition of the anterior and the posterior columns of the pelvis. And essentially, this is the sacral iliac osseous corridor where the actual screw is going to live in. So we're looking for that teardrop. So now let's talk about how we find it. So let's talk about the frustrum. So the frustrum is a 3D shape. So let's imagine a cone. So we can see this ice cream cone here. And if we rotate it to this angle, and we imagine that we're gonna cut off the tip, so we're left with the tip cut off and the cone without the tip. That cone without the tip, that's called the frustrum. And it'll look like this. And as we can see, it resembles that shape that we see here on the pelvis in pink. So that is what we're looking at when we refer to the teardrop. And so as we can see here on the frustrum along that dotted line, that is exactly where that screw is going to lie. So now let's talk about how we can visualize that. So there's a couple of images that we're going to be taking during the procedure to ensure that the trajectory is in line. So the first one, while the patient is in the prone position, we're going to focus on the outlet view. So to do that, that means we're going to drop this C-arm 45 degrees towards the patient's foot. And that's going to give you a visualization of the pelvis. So it'll look something like this on the right. And this allows us for real-time monitoring of the screw placements through that fluoroscopic imaging. The next view is the inlet view. So we're going to drop the C-arm 45 degrees towards the patient's head. And this is going to give us the inlet view, which we see here on the right as well. Then we'll have the AP view, which is the anterior posterior view. And this is where we start. So in order to get the obturator oblique view, which is the important view that we're looking for, we're going to drop the C-arm 20 degrees cephalad towards the coronal plane. So that means 20 degrees towards the patient's head. And then depending on which side of the pelvis that we're going to be working on, we're going to drop the C-arm using the rainbow function 20 to 30 degrees until we can see the widest teardrop possible. And so right there, that's how we're going to position the obturator oblique view. And this will help confirm the precise location of the screw for a stable fixation. So once we see the teardrop, we're going to want to try to leave a sufficient rim of the anterior inferior iliac spine on the outer ridge. So here on the right, that blue image, this is from an article from Dr. Park, and here they're visualizing the teardrop, and we can see that they leave a sufficient rim here on the anterior inferior iliac spine. And so on the image on the left, that's another example of a visualization with the guide wire perfectly in the center of the teardrop and that space on the right, on the left, sorry. So this will allow for the optimal placement of that teardrop. And we want to make sure that it sits right above the femoral head and the acetabular sulcus. Okay, so now let's talk about the ideal placement within the teardrop itself. So the ideal placement will lie at an intersection of two lines. So first, if we drop a vertical line directly from the apex of the teardrop, as we see here, that yellow line, and then we draw the longest possible horizontal along the width of the teardrop right there, right at that intersection, that's going to be a great place to put your screw and guide the wire that you start out with. So if you're in that position, you're optimally within the teardrop and it's going to go smoothly all after that. So now let's talk about the advancement of the guide wire. So here, we're going to use the help of our C-arm tech to do the sequential imaging. So they can do the lateral, the AP, the inlet, and the outlet views. And as it goes along, we're just going to be watching that the threaded guide wire is advancing and positioned right over the sciatic notch and within the margins of the iliac bone itself. And they can just keep going quickly through these views, AP, lateral, inlet, and outlet, and we can watch how the guide wire progresses. So now in terms of sequential advancement, let's talk about how that looks. So first, we're going to get an AP view. And on the AP view, we're going to look for the S1 end plates and the S1 and S2 foramen. And then the guide wire is just meticulously advancing on the AP view. So what we're looking for on the AP view is basically your cranial caudal angle, because the pin is going to need to pass 35 millimeters inside the sacral bone. So within the ilium, it's going to go another 35 to 65 millimeters of cancellous bone, and this is going to be a very long screw. So now let's go over the inlet view. On the inlet view and outlet view, we're going to confirm the placement of the wire, that it's in the sciatic buttress, and we're just making sure there's no violation medially, like towards the bladder or the vascular structures, which were some of the risks that I discussed earlier. So we're just going to make sure that it's placed in that optimal location. And finally, for the lateral view, we want to make sure that we get a true lateral. So how to identify this? We're going to look for a couple specific locations that we want to identify. So we want to identify the acetabulum and the sciatic notch and make sure that both of those sciatic notches are perfectly superimposed. And that way we know that we have a true lateral view. And we're going to keep confirming that the wire is headed towards the anterior inferior iliac spine. And now the ideal screw placement would be great if you can get the screw 1 to 2 centimeters above the acetabulum. And it'll be even better if we can get the threads of the screw to graze the sciatic notch, because there's a nice corticocancellous junction of the bone there that can really help grab the screw. So after we've placed the wire, you can put the cannulated screw over the wire under fluoroscopy and then remove it. So according to the literature, the best screw dimension is between 8 to 9 millimeters and 70 to 110 millimeters long, if you want to avoid catastrophic failure. And so this range will be based on the brand of the screw that you're using, and the article notes that the ideal screw length is usually a 8.5 screw by 100 millimeters, for example. So now let's finish off with a quick case. So we have a 61-year-old male, and he presents with intense lumbar complaints, which are 50% bilateral leg pain, and 50% back pain. And the radiculopathy he had in his leg was rated a 6 to 8 out of 10, and the pains were more severe on the right leg. So the patient has already tried a course of conservative measures, which include epidural injections, some therapy, bracing, acupuncture, and use of non-steroidal anti-inflammatories. And he had an MRI and CAT scans done, which showed a significant amount of hardware loosening, as we can see here, and lucency. And he ended up having an infection, which needed to be addressed. So now the question is, what's going to happen with the hardware that's in there? So the screws posteriorly had to be removed, and we obtained proximal fixation. And we placed distal sacral alar iliac hardware. And then afterwards, he noted immediate resolution of his back pain and radiculopathy, and he was able to return to all regular activities, including his work, within 3 months' time. After that, at his 1-year follow-up appointment, he still remained asymptomatic after completion of his antibiotics. So that is all for the presentation. Thank you very much.